Hello, hello. My name is Jones, and today we are going to look at jaundice. We are going to discuss jaundice in this session by looking at the definition. So, by the end of this lesson, you should be able to define jaundice. Should be able to talk about the risk factors to jaundice. You should be able to explain the pathophysiology of jaundice. Should be able to state the different types of jaundice. Okay, that is according to the pathophysiology that we are going to give you. You should be able to describe three types of jaundice. We are going to talk about the signs and symptoms of jaundice, and then we'll also look at the medical management, nursing diagnosis that are related to jaundice, and then we'll end by looking at the nursing management of jaundice. So to begin this lesson, jaundice is a symptom or a syndrome that is characterized by increased bilirubin concentration in blood. The other definition of jaundice is that it is the yellow color of skin and a mucous membrane due to accumulation of bile, pigment in blood, and their deposition in body tissue. So when you are trying to define jaundice, we are just looking at jaundice as the yellowish discoloration of the skin, mucous membrane, and the sclera. Of course, this will come because of build-up of bilirubin. So that's why jaundice sometimes is called hyperbilirubinemia. Okay, so that is the definition of jaundice. Okay, so it is also important that we learn to distinguish jaundice from conditions like cholestasis, calotinemia, and quinacline injection. So, when you talk of, let's say, cholestasis, okay, it refers to decreased rate of bile flow. So, depending on the situation, jaundice and cholestasis may coexist, or each may exist without the other. Although many sources confidently say that jaundice can be recognized when the serum bilirubin rises to 2 to 2.5 milligrams per deciliter, experienced clinician often cannot see a yellow skin coloration not until the serum bilirubin is at least 7 to 8 milligrams per deciliter. So cholestasis is necessarily one of those conditions that may coexist with jaundice, or one of them may exist on their own. And when you're looking at cholestasis, we are just referring to decreased rate of bile flow. Okay, so jaundice should also be distinguished from the yellow or green skin color that result from calotinemia or quinacline injection. Okay, so when one eats large quantities of green and yellow vegetables, tomatoes or yellow corn may result in excess carotene intake. The resultant yellow skin color is differentiated from jaundice by the absence of yellow color in the mucous membrane and the sclera. Okay, so the urine in this condition will also be normal, and the accentuation of yellow-brown carotenoid pigment in the palm, soles, and the nasal folds can be seen when someone has calotinemia. Okay, so we see this mostly during harvest of maize or harvest of corn, when people try to eat so much meat and then or try to eat so much of maize, and then they may have this yellowish discoloration within the palm. Okay, but it's different from jaundice. Okay, in that this one may come because of increased carotene intake, okay, or excessive carotene intake. Okay, then quinacline, commonly used for treatment of giardiasis, may produce a yellow skin color, but the urine will remain normal. Serum bilirubin levels are normal in patients with yellow skin that is caused by carotenemia or quinacline. So this is another condition in which when you're treating someone for giardiasis, they might have this yellow skin coloration, not necessarily as jaundice, okay, but because of the presence of this chemical, which is quinacline. Okay, so jaundice has some classifications that we also need to understand for purpose of also understanding the pathophysiology. We need to appreciate these. We need to appreciate these classifications. Okay, so there is hemolytic. Okay, that is hemolytic type of jaundice, or there's hemolytic. Then there's hepatocellular, and then there's obstructive. So these are the different classification of jaundice. Okay, so we'll try to talk about the other types, but others will talk about these classifications necessarily as also types of jaundice. That there's hemolytic jaundice, there's hepatocellular jaundice, or there's obstructive. Necessarily, what we mean hemolytic is coming from hemolysis of blood cells. Then hepatocellular, it is coming because of pathogens within, or because of problems with the liver, because of pathogenesis to do with the liver, or having having a problem with the liver. Then obstructive is happening because there is an obstruction in the flow of bilirubin, okay, which is the sole culprit for causing jaundice. Okay, so we are looking at the classification. So there is hemolytic, hepatocellular, or obstructive. So when you're now looking at the risk factors, we can try to look at these factors based on these same classification. So when we say risk factors, we can say hemolytic jaundice. Some of the risk factors will come because of transfusion reaction. The risk factors may come because of hemolytic anemia. The risk factors of this jaundice may come because of severe burns, which causes increased breakdown of red blood cells. Then other risk factors to do with hemolytic jaundice have to do with autoimmune hemolytic anemia. Okay, so autoimmune diseases that may cause hemolysis of red blood cells may cause hemolytic jaundice. Okay, so when you're looking at this classification, okay, classification as hemolytic, classification as hepatocellular or obstructive. So we can say there's hemolytic jaundice, okay, there's hepatocellular jaundice, and then there's obstructive jaundice. Okay, so when there's hepatocellular jaundice, this will be due to pathology that affects the liver. So we have hepatitis, which is inflammation of the liver. So this can lead to jaundice. We have yellow fever, in which there is inflammation of the liver. So this can lead to jaundice. We have alcoholism, which can lead to problems with the liver. So this may lead to jaundice. And the type of classification will be called hepatocellular jaundice. Okay, so then we have obstructive jaundice. In obstructive jaundice, we can have extrahepatic or intrahepatic. Okay, so when I say extrahepatic, this is obstruction that may be caused by bile duct plugging from gallstone, an inflammatory process, tumor, or pressure from an enlarged gland. Then when I say intrahepatic, this can come because of obstruction from pressure on channels from inflamed liver tissue or exudate. So within the liver, if there's inflammation, then we are saying it is going to lead to intrahepatic. Then extrahepatic, we are saying obstruction that may be caused by bile duct plugging from gallstones or an inflammation process. It can even be tumor or pressure from an enlarged gland. So these may cause mechanical obstruction. Okay, so talking about types or classification of jaundice, you can talk of obstructive jaundice, you can talk of hepatocellular jaundice, and then you can also talk of hemolytic jaundice. So these are the risks according to the classification type of jaundice. Okay, so if you have to talk about the pathophysiology of jaundice, Pathophysiology starts with etiology. It starts with the causology. It starts with what necessarily has led to the jaundice. So, in the pathophysiology, if you want to explain hemolytic jaundice, okay, so it will be caused by increased destruction of red blood cells, resulting in the inability to excrete bilirubin as quickly as it forms. Then, when you're talking of pathophysiology due to hepatocellular jaundice, it means it is resulting from inability of diseased liver cell to clear normal amounts of bilirubin because of defective uptake, consumption, or transport mechanism. So, in the pathophysiology for hepatocellular, it is resulting from the inability of the liver. In the pathophysiology to do with hemolytic, there is increased destruction of red blood cells. Then, if you want to explain the other third way of explaining the pathophysiology of jaundice is to do with obstruction jaundice. So this will come because there is some obstruction in bowel disposition. Okay, so cause mostly is obstruction in the bowel disposition. So mucous membrane, sclera, who are going to have the yellowish or the tinge of jaundice because there is an obstruction in the flow of jaundice. So this is now deposited in the skin, mucous membrane, and the sclera. Okay, so it is important to know that jaundice is a symptom of an underlying condition that impairs the excretion of bilirubin from the body. So when you're looking at this hepatocellular, when you're looking at this obstructive jaundice, we have a condition which is coming because of the risk factors to do with the obstruction. Okay, so now let me try to explain a bit of pathophysiology of jaundice using one angle. Okay, that is talking about hemolytic jaundice. I'm going to explain the pathophysiology of jaundice using the hemolytic angle or classification. So, as the 120-day lifespan of red blood cells comes to an end, or the cell becomes damaged, the cell membranes become weak and susceptible to rupture. As this old or damaged cell circulates through the reticuloendothelial system, the fragile membrane eventually ruptures and the content of the cell are expelled into the bloodstream. One of the cellular components that is released when this happens is hemoglobin, which is ingested by phagocytic cells called macrophages. This phagocytosis splits the hemoglobin into constituent hem and the globin portions. The globin portion is a protein that breaks down into amino acids and plays no role in the pathogenesis of jaundice. Okay, then on the other hand, when talk of the hem, okay, it undergoes an oxidation reaction that is catalyzed by enzyme oxygenase to give biliverdin, iron, and carbon monoxide. The biliverdin is a green colored pigment which then undergoes a reduction reaction to yield a yellow pigment called bilirubin. This reaction is catalyzed by cytosolic enzyme biliverdin reductase. So nearly about 4 milligrams of bilirubin for each 4 grams of blood is produced in the body every day, mainly as a result of hem from expired red blood cells being broken down. The remainder is produced necessarily from other sources of hem, such as failed red blood cell synthesis and from the breakdown of proteins that contain hem, such as cytochrome and myoglobin. So this insoluble bilirubin, that is referred to as free, indirect, or unconjugated bilirubin, and is going to move towards the liver through the bloodstream, and it picks on, and it is picked or it is bound to albumin. So when then it reaches the liver, bilirubin is conjugated with gluconic acid, or we can say it is characterized. It is catalyzed by UDP gluconeotransferase. When this process happens, it will give bilirubin a digluconate, or we are now going to say the bilirubin has now been conjugated. Okay, so when now bilirubin is conjugated, it becomes water soluble. Okay, so before the bilirubin reaches the liver, it is in the unconjugated form, and unconjugated form of bilirubin is fat soluble. But after it passes through the liver, after it passes through conjugation, okay, it becomes water soluble form, which can easily be excreted. So the conjugated bilirubin then will leave the liver and enter the biliary tree and the cystic ducts as part of bile. Okay, so they now enter in the biliary tree and the cystic duct as a part of bile. Okay, so when they are now released in the intestine, they are converted. Okay, so when they are released now in the intestine, the bacteria in the intestine will then convert the bilirubin into urobilinogen. Okay, so from the biliary tree, the bilirubin is now going to be deposited in the duodenum. So when it is deposited there in the duodenum, okay, which is part of the small intestine, or the first part of the small intestine, okay, it will then be converted by the activities of the bacteria within the intestine, okay, into urobilinogen. This urobilinogen is either converted into stecobilinogen, and then when it is converted into stecobilinogen, it will be excreted in feces. Okay, and it can also be, this urobilinogen can be reabsorbed by the intestinal cells and taken within the blood and excreted via the kidneys. Okay, via the kidneys in the urine, and be able to give urine its color. Okay, so this is necessarily what happens when in the normal conjugation of bilirubin. So now, if at all there is a fault within this conjugation process of bilirubin, or then jaundice is going to result. Okay, and it is going to cause the yellowish discoloration of the skin, nail bed, and the whites of the eyes. Okay, which you call the sclera. Okay, and there will be build-up of bilirubin in body tissues. So when you are looking at this process of the conjugation of bilirubin, our metabolism of bilirubin, we can simply establish that there are different types of jaundice. Okay, and when you're looking at these types here, we are looking at the level at which it is happening. So the different types of jaundice, according to the level at which it is happening, we can say pre-hepatic jaundice. Okay, so pre-hepatic jaundice is going to result into increased levels of unconjugated bilirubin in blood. Then we have hepatocellular jaundice. Okay, it is also going to lead to increased levels of unconjugated bilirubin. Okay, because there is a problem there to do with the liver. So then the other type, according to the level, okay, that is the level which is bring about the jaundice, is the post-hepatic jaundice. And when we talk of post-hepatic jaundice, mostly it is obstructive jaundice, or the risk factors that we have discussed because of obstructive jaundice are going to result. Okay, so in discussing about the types of jaundice according to the level, so we are saying pre-hepatic jaundice. In here, the bilirubin level is disrupted prior to the transportation of blood to the liver. Okay, so this bilirubin, which is supposed to be carried by albumin, okay, which is a form of transport to the liver, so there is a disruption in the transportation. So examples of conditions, okay, that will come because of this, where we have the pre-hepatic type of jaundice is hemolytic anemia and sickle cell disease. So in this condition, someone may have pre-hepatic jaundice. Okay, then we have hepatocellular jaundice. Here, the disrupted bilirubin is caused by the disease of the liver. And examples of conditions that may cause this hepatocellular jaundice include liver cirrhosis and Gilbert syndrome. Then we have post-hepatic jaundice or obstructive jaundice. Here, bile and the bilirubin are contained inside, and it is obstructed and prevented from draining into the digestive system from the gallbladder. So examples that may cause obstructive jaundice or post-hepatic jaundice, okay, may include tumors and gallstones. Okay, so you can even try to add this within the pathophysiology that is to do with these types according to the level at which the jaundice has been caused. Okay, so now let us look at the clinical manifestations, or we look at the signs and the symptoms. This will be based on the assessment that can be done. So the signs and symptoms that can be seen in jaundice include dark, foamy urine due to increased bile in the urine. Okay, so remember the urobilinogen, which is absorbed by intestinal cells, okay, is now then excreted in the urine. So you're going to have dark foamy urine that is due to increased bile in the urine. Then we have light or day color or clay colored stool, which is due to lack of bile in the bowel, okay, or in the small bowel. Then presence of jaundice within the skin, okay, may cause pruritus. Okay, so bile acids, when they are in high amount, or when there's increased amount of bile salts in the skin, it leads to pruritus. Then we have the other symptoms or signs and symptoms here that we can see is inability to tolerate fatty foods, okay, because bile is involved in the emulsification of fats in the small intestine. So person may now not tolerate fatty foods. Okay, then there is mild to severe illness with the other symptoms such as anorexia, fatigue, nausea, and weakness, and possibly weight loss. Okay, so these can be seen when one has the jaundice. Then in the medical management, okay, so when you discuss the classification, we said it can be hemolytic jaundice, it can be hepatocellular or obstructive. So in the medical management, you are going to treat this patient based on the cause or the predisposition. Okay, so what would be some of the nursing diagnoses? Okay, so some of the nursing diagnoses that we can appreciate for a patient with jaundice is disturbed body image, which is related to jaundice. Okay, there's yellowish discoloration of the skin. There also the sclera. So there will be a distorted body image, or there is disturbed body image, which is related to jaundice. Then there can be impaired skin integrity, which is related to hyperbilirubinemia. Okay, this is because the person is going to have pruritus, which will cause him or her to be scratching him or herself. So this may affect skin integrity. Okay, so how do you manage this condition as a nurse? You can assess and document the degree of jaundice of the skin and the sclera, and then intervene to reduce anxiety, reinforce the healthcare provider's explanation about the cause and expected outcome of jaundice. And then you can also encourage the client to express feelings and concerns that they may have about their body image, and advise some of the remedies that they can use, like increased glucose or high carbohydrate diet, okay, which will help in the breakdown of of bilirubin. So you can also promote adequate nutrition, okay, to the patient, and also encourage consistency, okay, and reduce on protein intake. Okay, reduce on protein intake as advised by the health practitioner. Okay, this is necessarily recommended to avoid certain complications that may come. Okay, so today we have been looking at jaundice. Okay, jaundice as a symptom. Okay, that is necessarily what we have been looking at. So jaundice is seen or is mostly discussed in let's say neonates, where neonates, because they are born with a higher HB, so they may tend to have hemolytic jaundice. Okay, hemolytic jaundice, because the increased red blood cells that they are born with are not necessarily needed when they are now able to enjoy atmospheric air. So after some few 3 to 5 days, these may be broken down. Okay, so we see jaundice for people that abuse alcohol. Okay, so due to liver damage, they may have jaundice. That is to do with adults. So in liver cirrhosis, we may see jaundice, okay, as a condition. So in our discussion, we discussed that jaundice is the yellow color of the skin and mucous membrane that is due to accumulation of bile pigment in blood and the deposition of this bile in body tissues. Okay, then in our discussion, we distinguished jaundice from a condition like cholestasis that may bring a similar clinical presentation of yellowish discoloration of the skin, but may not have other signs and symptoms to do with clay type of stool that might be seen, or foamy urine or dark urine that is seen in jaundice. Okay, and also when you talk of cholestasis, the bilirubin levels do not necessarily increase that much. But when you're talking of jaundice, you see that bilirubin levels may increase to more than 2 or 2.5 milligrams per deciliter. So it may increase to that, but mostly clinically, we tend to see the yellowish discoloration of jaundice when the jaundice is, or when the bilirubin levels are above 6 milligrams per deciliter, or it's between 7 to 8 milligrams per deciliter. That's when we tend to see the yellowish discoloration of the skin. Then we also distinguished jaundice from calotinemia. You know, when you're eating a lot of calots, you get it, then there will be increased calotin intake. This may result in yellow skin color, but this can still be differentiated from jaundice because of the absence of yellow color in mucous membrane and the sclera. Okay, so or the normal urine will be seen in this condition. Okay, then quinacline injection, okay, which is used for treatment of giardiasis, may produce a yellow skin, but the urine is going to remain normal. Serum bilirubin levels also are going to remain normal. So we try to distinguish these conditions that may have a clinical presentation similar to that of jaundice. Then we looked at risk factors. Risk factors that we looked at were classified under hemolytic, hepatocellular, and obstructive, which can be looked at classes of jaundice or types of jaundice depending on the write-up that you might be using. Okay, but otherwise these are necessarily classification of jaundice, okay, based on the cause. Okay, so the cause, hemolytic jaundice, it can be transfusion or destruction in the red blood cells. Then hepatocellular, conditions of the liver. Obstructive, there's two types. We have extrahepatic and intrahepatic. Extrahepatic, anything that is happening before or after the liver. So it's outside the liver system. So obstruction may be caused by bile duct plugging in from gallstones. So that will cause extrahepatic type of jaundice. Then we have discussed the pathophysiology, but depending on these three classifications, hemolytic, obstructive, obstructive or hepatocellular, we can discuss the pathophysiology of jaundice. Okay, so in our example of pathophysiology that we looked at, we picked the angle of hemolytic. Okay, hemolytic to do with the destruction of red blood cells and necessarily what is going to result after this destruction. Okay, then within our lesson, we went on to look at how jaundice may come due to pre-hepatic reasons, due to hepatic reasons, and post-hepatic reasons. Then we also said that in the treatment, we are going to treat according to the cause of the jaundice. That's the way we are going to treat. And then we identified some problems that may come or be associated to jaundice. So these are the nursing diagnoses or nursing problems that may be associated to jaundice that we have discussed in here. Okay, then we discussed just a few points on the nursing care that we can give to this patient. So from me, I'm saying thank you very much and keep studying.